Hi, everyone, and welcome. We hope you're as excited to be here as we are. We're going to do some introductions and then quick instructions, and I will begin. My name is Denise Fixon, co-founder of hsconnect.org. I've been living with HS for 43 years, a little bit over, and I've been a patient advocate for going on 30 years. Very passionate about HS, very happy to be here. Dr. Resnick?
Good morning. I'm happy to be here too. I practice complex medical dermatology and surgery in Miami, Florida. I've been practicing for over 25 years, and I am happy to moderate this session.
Great. Thank you. We're very happy to have you here. So in a moment, we're going to introduce the speaker. And after the presentation, as mentioned, there'll be a quick 20-minute break. For your questions, please do put them in the chat. Dr. Resnick and I are going to be moderating that section. And then after the break, we will come back and both physicians will answer as many questions as time allows. So Dr. Resnick, with that said, would you like to introduce today's speaker?
It's my pleasure. Our speaker today is Dr. Kimberly Curseen. She's the Director of Outpatient Supportive Care at the Emory Palliative Care Center. She's board certified in internal medicine, geriatrics, and palliative care. She specializes in caring for patients with serious and chronic, oftentimes debilitating illnesses like HS. In her palliative practice, she provides pain and physical symptom management, social support, and spiritual care. Her goal is to help improve quality of life for patients coping with serious, painful chronic illnesses.
Okay, thank you very much. And thank you for joining us today, Dr. Curseen.
Okay. Hi, it's very nice to meet all of you.
The stage is yours.
Okay. All right. And I'll start screen sharing. Oh, it's there. So I first want to say thank you so much for having me. Palliative care and HS is fairly new in a collaboration, and so it's really wonderful to be here um, at this institution collaborating with such a wonderful dermatologist, Dr. Laura Orenstein, who brought her clinic to our clinic, and it's been really wonderful. So I titled this The Experience of Pain. I first want to explain I have no relevant disclosures. I think it's always important to sort of make sure that we're all talking about the same thing. So what is pain? Well, the technical definition is an unpleasant sensory and emotional experience associated with actual or potential tissue damage, described in such terms of damage. So, why I like that definition is because I like to focus on the part that says actual damage or potential damage because it leaves open a part of the pain that is subjective. Um, when we're thinking about HS pain, what are some of the questions that we're going to try to answer? Well, why is HS painful? Why is it important to address the pain? What are the barriers to addressing pain? What are the pain options that I have? And then where should I seek help? So, why is HS painful? Why am I itching? And why am I burning? Well, there's several different types of pain. And in the medical profession, we use fancy terms like nociceptive pain or neuropathic pain. When we say nociceptive pain, all we mean is that the pain comes from the tissue itself. So if you have an abscess, you have a tunnel that causes, and there's infection that causes tissue inflammation. That's somatic pain. Neuropathic pain, which is really complicated and difficult to treat, happens on two fronts. One, um, the chronic inflammation damages the nerves, and that's what gives you that burning and that itching sensation on top of these sharp, like electrical kind of pains. Um, that happens. If you continue to have that insult, that can change pathways in the way your brain starts to interpret the pain, and that you get something called central sensitization. And that's when the brain is really struggling to try to figure out what's happening neurologically, and it can send pain signals even when there's not a stimuli. And and it can also be difficult to try to explain, particularly to providers. But when you look at the skin, you can kind of see where the nerve follicles are and how it all relates. So why is it important to address pain? Well, pain in HS relates to more highly with poor quality of life and even than the disease severity. So the pain seems, even if you have multiple lesions, how painful those lesions are may not necessarily be related to the severity often of the disease. The pain is sharp, throbbing, aching, burning, and itching. And it can change character depending on the day, depending on what you're doing, depending on how where the abscesses are. Um, and that can be disconcerting because it leaves you feeling with a sense of not feeling in control and difficult to explain. HS has one of the most devastating impacts on quality of life than any skin disease. So, the insult of dealing with the chronic pain and the skin disease in itself can lead to poor mental health, poor loss of work, which leads to financial distress. It impairs intimacy. It can lead to chronic pain. And the medications that we expose you to can increase risk for substance misuse disorder and chemical coping. And there are reasons for that. So I think it's important to try to figure out when we talk about pain, the way a provider is sort of thinking about it. When you tell us you're in pain, we want to know, is this acute pain or is this a chronic pain? Well, acute pain, the definition is it's sudden, it's defined, there's a clear cause, and the duration is short. So you have an abscess, it's about to come to a head, it's causing a lot of pain, you're in the ER. We can see that, and our response to that is different. Your heart rate's up, you're sweating, you're feeling terrible. And when you're in crisis, it can affect your whole person. We are very good and adept at identifying suffering. Where we struggle in the medical profession is the chronic pain. So, chronic pain is defined as pain that persists longer than the course of natural healing. So, patients will have, wounds that have healed and they still have pain and discomfort. And you go to your provider and they're like, well, the wound's healed. There's not drainage. I don't see anything. I read notes like this all the time. The wound is healed. It looks clean. The patient's complaining of pain, but everything looks fine. Um, and what we're failing to realize is that pain, that chronic pain, can develop even after the area is healed for a variety of reasons. And chronic pain is pain that persists longer than for a long period of time. We usually say about greater than 6 months, and we don't mean that you have to be in pain all the time. So that's also a misnomer that chronic pain you are in pain every day. Well, no, that pain can be episodic, it can be several times a week, but it's chronic. It's not going away, and for many patients, it will last months to years. It has and the manifestations that we see in chronic pain, instead of sweating and heart rate and signs of physical discomfort, it switches to more psychological and emotional effects. So we don't see the heart rate or blood pressure increases, but what we start to see is disturbed sleep, depression, mood, inability to function, loss of appetite, which throws providers off. When you have chronic pain, it's often that patients will also develop total pain because the pain affects your entire body and sense of self. So we manage the physical symptoms. What's often a struggle for us is to recognize the anxiety or the anger and depression that are critical components when you have chronic pain because your life is interrupted. The isolation and the loneliness, financial distress, family tension. There's a very social component to chronic pain and also HS as well. And then the end for non acceptance, the spiritual distress that develops, the loss of self, the hopelessness, and the questioning of why is this happening to me, all wrapped up in pain. So when I'm working with patients, sometimes when they're feeling, pretty down on themselves, like, why can't I get out of this? What's wrong with me? Um, the medication's helping, but it's not quite. Or somebody told me that the pain's all in my head if I just thought positively. So I'll show them this slide to sort of explain the reason why we say such things or why they're having such a struggle. Because when you have physical pain, it's a vicious cycle. It's like and psychological discomfort start to become interlocked, and it feeds off of each other like interconnecting gears. So when you have pain, you avoid activity. You get deconditioned. The pain increases with decrease in activity. You have further avoidance of activity, further deconditioning. At the same time, when you're losing everything and you're not able to do the things you want to do, that feeds into fear, anger, and distress. Your mood gets low, depression starts, and that messes up your perception of pain. All your coping mechanisms become destroyed. So I explain to patients, if I give you medication or procedures to fix this part and I cut this wheel is still turning. So I have to address this as well. If I just address your psychological discomfort without addressing your physical symptoms are still turning, and we never get to address the pain. So we really have to approach both. And palliative and supportive care, our primary job is to assist patients with suffering, because when you have total pain for too long, then we see our patients really start to suffer. And I really love this quote by Dr. David Cassell, who's a pioneer in our field. And he defines suffering as a state of distress associated with events that address the intactness of personhood, interconnected physical, social, spiritual, or psychological aspects of self. And as you notice this doesn't actually say in suffering, it doesn't use the word pain. It uses, all of these. It really takes the idea of pain from something that's just physical, but to something that affects all aspects of your life and the way in which you view yourself. So I'm pretty sure there have been times where you all have been in pain, but you're like, "Oh, my arm hurts. Oh, this wound hurts," but you're able to sort of do your daily life. And then there may be times where you could have the exact same thing and you're completely undone. In that instance, you are suffering with your pain versus just having a primary physical discomfort. So, what are the barriers to addressing pain? I say, okay, Kim, all right, you define pain. So, what's the barriers to addressing it? Well, there are lots. And these are quotes that I hear from patients. There's a stigma of chronic pain. And patients tell me, I don't want to be seen as a drug seeker. I feel judged. They don't listen to me. The moment I go into the ER and I say pain, everybody's brains turn off. And I hate going to the pharmacy. They treat me badly when I pick up my medicine. I'm a fighter. I won't give in to this. I'm not going to give in to this pain. I experience discrimination when I say I have pain. People tell me it's all in my head. There's a lack of knowledge or access to resources. I have a doctor. My doctor says they don't treat pain. Okay, so what do you do with that? Some patients are fatalistic. There's nothing I can do. I just have to live with it. This is just going to be my life. It's never going to get any better. Um, I, you can't have your pain managed if you actually can't get to the appointments or even afford the medications. How about the side effects of the things that we use? Well, I don't want to be a drug addict. I don't want to take, anything that's I might become physically dependent on it. I don't want to be sleepy or constipated. And a big worry for a lot of patients, because many of our patients that we see here have other comorbidities. I can't have organ damage too. I don't know what these medications are doing to my body. Their financial limitations. Wow, doctor, that sounds great. Thank you for that medicine that my insurance does not cover, or the copay's too high, or they won't cover seeing that provider. And then we also have to think about it, which is something that medical professionals don't think about, the time. Yes, go to counseling and physical therapy. That's awesome, but I can't miss work in the middle of the day. They don't have appointments, after 5. And I just don't have time to deal with this now when you have multiple other things going on. So, sort of sitting with that. And these are things that we have to be conscious of, or providers need to be reminded of when we're making treatment plans. So, treating pain from HS requires a multimodal approach. So, even though I said all of this, there still is no way to get around management unless we approach it from different areas. So, there's no magic pill or one modality that's going to help everyone all the time. So we need to be open to pharmacology, which that just not includes your traditional medications, but also supplements and complementary therapies. I'm like, if you put it inside of your body and it did not come from your body, it's a medication, no matter how you cut it, whether it's made from big pharma or somebody's mixing it up in their backyard. It's pharmacology. Um, we need to, interventions like incision and drainage, nerve blocks, injection and wounds, wound care is definitely a part of pain management. If you don't treat the process or what's actually happening to you, we can give you lots of medication, but oftentimes we just need to treat what's happening and modify, do what we can to maximize HS care as well as provide interventional support. As we showed you earlier, we need to treat the psychological aspects of pain and what that's doing to you emotionally. The pain is not in your head, but the the distress that the pain causes creates the emotional and the psychological distress that, if not addressed, impairs your ability to manage pain and function in your normal lives. And then there also has to be social support. There has to be connection and people going through what you're going through and a sense of community, which always helps with any sort of living with a chronic illness and including chronic pain, and actually resources to be able to access the wonderful things that are out there for treatment. So thinking about, there's a wonderful study that's been done and a wonderful paper that I think everybody should read called Pain Management in Hidradenitis, a proposed treatment algorithm. It's really elegant. It was published in 2021. And this is sort of the standard of what if somebody who was not familiar with HS would go to this paper and this is how they would approach it. So they start with acetaminophen, or the trade name, like a Tylenol, 500 milligrams, 4 to 6 hours is needed. But I explain when you are in acute pain crisis, it's going to last probably for several days. So I would modify this algorithm to say that it should be on a schedule uh, initially to try to get ahead of the pain, and then once the acuteness is better, then back down to as needed. Um, Topical nonsteroidal anti-inflammatories are excellent. Do not put them inside the wound, but for around the areas that are causing distress can be very helpful. Systemic nonsteroidal anti-inflammatories, and what we mean by these are um, your ibuprofens, your naproxens, trade names like Motrin or Aleve. They didn't put there's other medications like Celebrex and meloxicam. They're nonsteroidal anti-inflammatories, but they have a little bit of a different pharmacology. But using those as your second line, thinking about in intralesional injections and incision and drainage for symptomatic relief. If you're not getting anywhere with that, then the HS community has relied heavily on tramadol as their first option. And what I'll say to you about tramadol is a great first, can be a good first option. When you get over the age of 65, it becomes a little tougher, and it does have some drug interactions, which we should be aware of. And other short-acting opioids, and they're recommending that just for a short term, because opioids have side effects, which we'll talk about later, but not using that as the primary mode of treatment. Once pain has become refractory, then we need, um, re-looking at or becoming better at trying to manage the HS-directed disease therapy. So treat the cause. If you treat the cause, and the pain will get better. At the same time, if your pain's been refractory, there may be some other psychological comorbidities that you are experiencing. We have to deal with those going back to that wheel. If we just deal with one and we don't deal with the other, we're not going to get anywhere. Um, Really paying attention to where we often drop the ball is the non-pharmacologic management of pain, which is, excellent wound care, good physical therapy, and the other modalities, which sometimes may be limited by access or or just availability, but they are incredibly important. And thinking about, and this is where in the pharmacology, in traditional pharmacology, we use neuropathic medications like gabapentin or duloxetine or or Cymbalta. It's like the little bounce. If you see the commercial, a little bouncing ball, like pain hurts or depression hurts, but those can be incredibly helpful. They don't work right away. They need to be taken on a schedule, and they have side effects. They can make you sleepy, feel out of sorts. So they're great medications. We use them often, but they can sometimes be difficult. And as you get a little older, a little more difficult to tolerate. Um, when you the tissue or the burning pain, nonsteroidal anti-inflammatories, there's a lot of inflammation. You will get a little more bang for your buck treating the inflammation. Like I have patients who will be given oxycodone or morphine for their wound pain, and they're like, it helps, but I'm really struggling. But you know what helped me? They gave me this shot, and it's usually something called Toradol, a really strong anti-inflammatory, or they gave me this big horse pill, which is ibuprofen, and it really helps. So always thinking in your mind about treating what the underlying cause of the pain and discomfort. And then again, medications like duloxetine also helps with tissue pain. Um, other considering other adjuvant therapies like topical lidocaine, not inside of open wounds, but around places or wounds that might have healed, that chronic part, trying to deal with the chronic pain that's coming from the scars and lesions. And those scars and lesions can definitely hurt when you're getting to the end and nothing is helping, then referring to a pain specialist referral, especially if you are n- stuck with having to use extended opioids if they're starting to become part of your treatment plan. It'd be important to have a specialist referral to also help with other options. So I work a lot with cancer, in addition, to I work with rheumatologic illnesses and HS, and medical cannabis, everybody's using it. I tell people don't eat, any brownies in the waiting room, that other people are sharing because it likely has medical cannabis. Um, so what are some of the pros and cons of medical cannabis, right? So the possible pros, because the problem is that we don't because it's federally legal and it's a Schedule One medicine, which means it has no medicinal or medical use whatsoever, according to the federal government. Then the studies in this country have been limited. So a lot of the studies that you see online or the papers that you read, when you really look, are panels of experts, small patients population sizes, or they're at the laboratory level. So that's why I use possible pros. There's promising evidence for neuropathic pain and muscle spasticity. There's actually a drug moving through based on marijuana looking specifically for muscle spasticity. It may help with itching because itching and pain travel along the same nerve fibers. So when you feel itch, so sometimes neuropathic pain, your brain doesn't know how to interpret it. Sometimes it interprets it as itch, sometimes it interprets it as burning or feeling like bugs crawling, but it thinks it helps with that. Has a better for patients side effect profile than opioids. It has some antioxidant and anti-inflammatory properties. The cons is that there's poor evidence in HS, as it has poor evidence in most everything, even though it's getting better. There's unclear dosing and quality control. So, these aren't tested, and medical cannabis companies do internal quality controls. Um, but we are really relying on the industry to monitor itself. And relying on them to be good actors, and sometimes that can have some problems. There is a risk of dependence upon cannabis. The risk is a lot smaller than opioids, and usually people are using it high doses. High THC preparations can cause altered mental status and falls, disassociation, apathy. Many patients who are already struggling with a chronic illness or having busy lives, the THC component can really make it difficult for them to use. Um, and the THC component, it can actually potentiate the craving for opioids. And we'll talk about CBD too, while the CBD component can lower the craving. And this is some work coming out of Mount Sinai. Their drug interactions. So if you're a diabetic, may have to adjust your oral hypoglycemics. It can lower your blood pressure, increase your heart rate just a little, which freaks out your medical providers. It can potentiate and increase the 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 effectiveness of antidepressants, which can be a problem. And one thing I didn't mention here is that it can interfere with prograf levels for people who are on anti-rejection medications, and then it remains federally illegal, so it makes it difficult to get and puts you at risk, depending on what state you live in here. So for marijuana, there are two parts. So THC and there's CBD. THC can be sedating, anxiety producing is the psychoactive part of the medication. CBD is the non-psychoactive part. There's can relieve from convulsions and nausea. Both have some analgesic effects. Different strains of medical cannabis that I think you should be aware of. Um, I tell people just to kind of remember three: the S, the I, and the hybrid. So sativa is activating. So sativa is stimulating. Um, indica is relaxing. So sativa for stimulation, indica puts you in the couch. And hybrids are a combination of both. So a little more information. If you're working with a medical cannabis provider, they may give you two things. And so if they provide you like, hey, I'm trying medical cannabis and they say use this during the day or use this during the evening, then a patient suffering from fatigue or depression may use sativa during the day and then may use an indica strain at night. Just plain old CBD. Some patients are using it for treat with seizures, anxiety, pain. Um, but it seems to offer little or no psychoactive effects. CBD from hemp has been legal in this country since the Farm Act in 2020, has some anti-inflammatory effects, theoretically, anti-anxiolytic effects, theoretically, and they're working on studies to evaluate this further. And then just as a caution, there is a little bit of THC in hemp, and as humans are, we extracted it all, created something called Delta 8, and Delta 8 has no medicinal purposes. It'll just get you high as a kite, and it's not safe, so don't use that. Opioids, significantly better pain relief versus placebo. Opioids do not outperform other non-opioid treatments for chronic pain as far as our current data shows. Um, and opioids perform similarly to nonsteroidals and tricyclic antidepressants like Elavils or anticonvulsants in improving pain and physical function scores and neuropathic, tissue pain, central sensitization, and mixed pain. The problem is the risk of physical dependence, addiction, and development of opioid misuse disorder, worsening depression, constipation, itching, cognitive dysfunction, urinary retention, falls in older adults, and unintentional overdoses. And there's a subset of opioids that have immunosuppressive properties that may increase risk of infection in those receiving immunomodulating therapy. And this has been more and more of concern providers for people who get multiple infections. For patients with extensive disease and organ dysfunction, sometimes opioids is the only appropriate option. If your kidneys don't work or your liver doesn't work well, then NSAIDs, and you cut out the first part of the acute place. So this may be what you're able to do. So if you have to be on opioids, expect there's going to be continual reassessment of effectiveness and periodic dose reductions. Doctors may go with a medication called buprenorphine that's becoming more popular because it's an opioid agonist and antagonist. There's less risk of abuse, less risk of respiratory impression because there's a ceiling effect on um, there's a ceiling effect um, on on the opiate binding to your receptors, causing respiratory depression and some of the other side effects. Um, and buprenorphine is the opioid that's in the medication called Suboxone. But we use it a lot for pain, and it's a fine analgesic for pain. Tramadol has a long-acting, even has a long-acting preparation, which I find that it tends to be the dermatologist's drug of choice. Um, you kind of need to avoid it a little bit when you get over the age of 65 or use it with caution and really monitor it if you're on other antidepressants because it can lead because tramadol can increase serotonin. If you're on antidepressant, that increases serotonin, and there's something called serotonin syndrome, which can make you very, very ill. But also, sometimes patients experience anxiety, and if you have some cognitive impairment, they can get kind of confused and increase risk of fall. So, psychological therapies, depression and anxiety are common. in HS and affects pain perception. So there are two evidence-based psychological treatments that help distinguish physical pain and suffering. There are more, but these are the two that have the best literature so far. That you may be referred to cognitive behavioral therapy. This is not talk therapy, picking around in your brain, getting you to talk about your feelings, but these are structured sessions which are there to reduce the pain and give you really good tools to figure out how can I constructively manage these symptoms, and it gives you a roadmap. The other is becoming more popular, which is acceptance and commitment therapy. So for chronic pain, it emphasizes psychological flexibility through acceptance, being present in the moment, context, values, and then you have a committed action. But what it's really doing is it aims to eliminate the experience of suffering, because it's the suffering that prevents you from doing what you want to do, not just the pain. When pain absence is not feasible, because we don't have the ability often to get rid of pain 100%. HS has a will have pain intermittently throughout a person's life. So to tell them that there's going to be a psychological therapy that's going to make you believe you don't have pain is not realistic. But there are therapies that can help you accept what you have and figure out constructive ways to manage through those pain crises. Um, Complementary therapies, I know I'm running a little short over time. Um, Therapies like acupuncture has little evidence at HS just because of lack of study, but this might be the one insurance covers, but you have to be very careful. There are mind body interventions, energy therapies. When we think about supplements, I put low dose naltrexone here as a supplement, though it's really more of a traditional pharmacy, but the way we use it is in very low doses to increase your endogenous opioids. Alpha lipoic acid, turmeric, cherry juice, boswellia, ginger, devil's claw, all can decrease inflammation. And important thing about supplements, again, they're like medication, so you do have to monitor for drug interactions as well as side effects. So where should you seek help? Well, first you have to ask yourself some questions. Before you even I'm going to get help for my pain, you want to know, what do you expect from the visit? Do you need acute help with acute or chronic pain or both? What are you open to doing? Are you open to procedures or interventions? Is there something that's just off the table? Do I prefer to avoid traditional pharmacology? What options will my insurance cover? Am I willing to address the emotional aspects of my pain? And do I effectively feel like I can advocate for myself if I go to this visit, or do I actually need help from a support system? And the reason why you go through this is because once you answer these questions, it gives you more agency, and now you're empowered when you go into your visit. So, preparing for pain management. You gotta, when you're preparing for a pain management visit, you got to kind of understand healthcare providers. Unless you're trained in pain management as a secondary part of your medical training, or most physicians are poorly trained. So it's not you. It's not you, it's us. And the response to the opioid crisis, why we get all emotional when you tell us you have pain and we think that you're asking us for opioid, is because we have handled it in this country in a punitive way versus a medical way, although we're willing to work on this, and we are working on this. There's practice and policies that dictate treatment limitations. So sometimes providers don't treat pain because their practice won't treat pain, and they would do it otherwise, but they're not able to. There's also bias and structural racism and socioeconomic discrimination that's automatically built into the medical system, which makes it difficult to access everything that's available to you for pain management. So those things being true. So kind of having that understanding empowers you, and also to let you know that you're not crazy when you feel like you're not getting what you need from us. And then we keep a pain diary. The better you understand the pain, the better you can explain it to your providers. So just take time to write it down and jot down things about your pain and bring that into your visit. You want to set realistic goals and expectations. The goal is to manage pain to allow for acceptable quality of life and level of function. Being completely pain free is not a goal that often can be met, but management and respectful care is reasonable. Long-term monotherapy with opiates is no longer considered standard of care for chronic pain, and providers will reassess and attempt to modify this therapy for safer options. If you are having to be on opioids for a long time, you will expect to have controlled substance use agreements, urine toxicology screens, filling of naloxone, the reversal agent for in case of accidental overdose, pill limits, periodic dose reductions, strict adherence to appointments, because these are rigid expectations in pain management clinics. And some of it is clinic policy and some of it is state law, all designed to keep safe. But, it's hard if you don't know these things walking in because being able to do all the things you're having to do can be disruptive to your life. So having an idea that this exists can be really helpful and allow you to work with your provider. Pain level and character may change over time despite your best efforts in management. So none of this is your fault. So if your pain changes and you develop more pain, most patients say, "Oh, Dr. Christine, I'm so sorry. The pain and medication isn't working. I'm sorry to bring this to you." So they're actually taking it as a personal failure that their pain has changed. We expect it to change. And finding a therapeutic relationship with a pain management provider can really be challenging. So where should you seek your help? Well, there are pain management specialists who just work with pain. Many pain management specialists also work with interventions like blocks, spinal cord stimulators, compounds, and and really, really incredible kind of fancy medicine, ketamine infusions, things that your primary care will not have access to. Pain psychologists are PhDs. They do not prescribe medications, but they are the people that would be delivering CBT or ACT therapy. They're physical medicine and rehabilitation specialists, so we often don't think about them, but yeah, they do. They're the specialty that actually restores function. So if you have a lot of muscle or tissue damage that's healed and you're feeling weak and you're not able to move around or you're having scars that are detracting, these are the people that are injecting you with Botox, putting you in good structured physical therapy, doing excellent exams and doing some manipulations that can be really helpful. There are people like me, palliative care providers who work with people who have serious illness. And in addition, we focus not just on what's happening to you physically, but we help with your spiritual and emotional systems. We provide resources. We try to relieve some of the social distress. Like my team is, you come as a team, we're form ninjas, as I say, that to relieve some of that. And we deal with medical management. There are naturopathic doctors where they actually have medical training and their training is focused on natural remedies and believe that nature is the most effective healer and combined with research. There are naturopaths. Those practitioners are not doctors. They didn't go to naturopathic doctor school. Um, and they focus on supplements, but as you can see in the next slide, a little bit of the difference. And there's integrative medicine specialists who approach really, they focus on wellness and they work with naturopaths and all the other very complementary disciplines. All of these disciplines possibly could be helpful, and what the slide here, and I'll make sure you have access to, is I've just laid out who prescribes medicines and who don't. So pain psychologists can't prescribe. Naturopaths may be actually able to prescribe depending on some state regulations. Oftentimes, anybody with a MD or a DO behind their name, insurance may cover the visit. It doesn't necessarily mean that they're going to cover the intervention that's offered. So, like for pain management specialists, they may say yes to the visit, no to the procedure without doing a prior authorization. Naturopathic doctors, NDs, may not be covered. Integrated medicine specialists, the visit might be covered, but visits by the other team members that could possibly bill you may not be covered. So, in summary, pain is a part of HS and should be managed to improve quality of life. Pain not only affects HS patients physically, but can have adverse effects on emotional health and causes suffering. The more the HS patient understands pain and pain options, the more control they can have over their health care. Educated consumer. Opioids have a place in acute pain management in HS, should be used with caution and long-term management secondary to side effects, but sometimes, depending on what's going on with your physical body, that might be the only option. And healthcare system, and there's no shame in that. Healthcare systems must acknowledge barriers to effective pain management for HS patients. And face and advocates should continue to work towards effective expansion of pain management options and education of healthcare providers, because there's also a dearth of knowledge of the illness as well as pain management. But long story short, you all deserve much better than what we are currently doing. So I just want to thank Emory Palliative Care Center, Emory Outpatient Supportive Care Center, and then Dr. Lauren Orenstein. And I apologize for going over.
No, thank you so much. That was amazing. Hi, everyone. Welcome back. So we're going to go through some of these questions. We had over 30 questions, so we're going to try to stay on topic of what we discussed today. Some of them were not on topic. If we can get to some of the other ones, great. If not, we want to remind you there's tons of resources on the platform. You can also visit hsconnect.org for everything HS. Okay, so let's get started. All right. So, Christine asks, is earthing and grounding helpful, beneficial to reduce inflammation? And Dr. Kim, I'm going to send that to you.
So say that one more time. Is earthing and grounding?
Yes, beneficial to reduce, helpful to reduce inflammation.
That's a really good question. I'm not sure I'm familiar with earthing and grounding, and I apologize.
Oh, okay.
But
I
Nor me.
am, but are you, Dr. Barry?
Nope.
No.
hold on.
Do you guys mind if I answer?
Yes,
Go for it.
please.
I
Yes.
actually love earthing and grounding, guys. I do it for many reasons. It's part of my meditation. And if anybody wants to contact me after this, the person who asked this question, I can send you some research and studies that back this up. But to answer your question, yes. So please contact me after this and we can talk a little bit further, okay?
Denise, would it be helpful if Dr. Resnick and I weren't aware? There may be people on the platform that just aren't aware of earthing and grounding, and if it's helpful, they might want to know what it is.
Earthing and grounding, and for those who cannot make it outside like myself anymore, it's connecting with the earth and energy and
Oh, okay.
electricity, good old fashioned electricity.
Energy work.
Energy. It's
Yeah.
energy. And if you just like put your feet in the ground or the sand and in the grass and connect with, there's so much energy in the ground. And it balances us out and connects with our dopamine, and it's amazing. I have a earthing mat upstairs because I'm pretty much homebound and bedbound now, and I'm like, how can I get back to that? I can't get outside anymore. So I work with a functional medicine doctor who said, here's how you can do it at home. But if you can be out with nature and do it that way, take your shoes off. You can use your hands, whatever, put your hands in dirt. That's why gardening can be so stress reducing. And you all know if you can get that cortisone level down from stress, what does that do? Helps with inflammation and all that beautiful stuff. It's amazing. I could just go on and on about this. So
No, I'm just so glad you did, because that you just illustrated why it's so important to have multiple providers, and that your allopathic and osteopathic providers just
yes,
don't get a great education in these areas that can be helpful. So we don't even recognize when we should be offering them. So
I
thank you
would
so
love to
much.
send you information on this
Mhm.
later if you don't mind. Okay.
Yes, please.
Let's see here. So, would it be beneficial, Dr. Resnick, for somebody to see a pain specialist or pain management for hidradenitis? Dr. Resnick, that's to you. Is he frozen?
Looks like Dr. Resnick is frozen.
Oh my gracious, we're having troubles. Dr. Kim, how do you feel about that? We will move on.
Yeah, I think it's very helpful, for a variety of reasons. The ability to manage complex pain is a discipline in itself. So when you just have minor pain that's coming and going and it's not interfering with the way you function through your daily lives, that can be probably effectively managed by a primary care provider, by your dermatologist. when it starts to become complicated, there are other options. There are procedures and things that can be helpful, compounding medications. And so, just like you get expertise and care of HS and the disease, modifying agents that you're on, you have to treat the symptom with the same expertise and care.
Okay. Okay. So are there, I know you went over some of these, and I do want to say that some of these questions came through before you started presenting. So, what other natural remedies might be helpful for HS pain? That could be for either Dr. Barry or Kim. I know Dr. Barry Resnick, we have discussed this in the past. Do you have any ideas for the community?
It's my philosophy that anything that makes you feel better is fair game. When I'm talking to new patients, I'm always talking to them about menthol and camphor. And there was a question about Vicks Vapor Rub. And
Yes.
I think that menthol and camphor are very effective pain modifying agents. We have a lotion. There's Sarna, which is commercially available, and that is menthol and camphor, and it moderates the pain. It changes the itch to a tingle or the sensation to a different sensation. It works for 20 to 30 minutes, but sometimes that's as good as you're going to get, and any respite is suitable. There's all of the nutritional supplements that people use, and the support groups are a great source for all of these things. And I am a firm believer in some of the things will work for some of the people some of the time. So curcumin and turmeric and apple cider vinegar and buttermilk baths. There are more things under the sun that we can count on. Whatever works for you is what you should be doing.
I love that. Well, that's our motto. HS is very personal, and find what works best for you.
Yeah.
What can I do to ease stinging? Dr. Kim.
You mentioned some of the remedies, like if you want we use a lot of topical lidocaine,
Okay.
which can be really helpful with relieving stinging. Again, menthol capsaicin can be helpful with relieving stinging. GABA, some of the pain medications that you're actually taking and ingesting can be compounded. So we will sometimes compound your tricyclic antidepressants, your gabapentins into a compounding cream that can actually relieve stinging. But remember, those are going to be primarily on the surface.
Okay.
We sometimes will also use even compounded ketamine topically in small doses. The risk of that is that it does get absorbed systemically. So using a lot of that is always not a particularly great option. But those have been incredibly helpful. Again, like hot baths and other topical agents can relieve. There are some pain management providers will do things like mesotherapy, where they'll actually inject scars, and that can be a little tricky if you have HS, but if there's something that's really well healed, that can be helpful. And nerve blocks can be done by pain management providers can be helpful because the nerves get tight and the scars start to change. Massage can be helpful as well. So if you ever hear the stinging and you find yourself doing this, what you're doing is actually going ahead and breaking the pain cycle. And I just say one thing about supplements. Supplements are medications. They have side effects. They metabolize through your liver and they can interfere with your meds. So check with your local pharmacist or your naturopathic provider just to make sure you're not working against yourself.
Always do that. Yeah. And we have articles galore on this on HS Connect. So here is, we went over the grounding one. Cohen asks, what are your opinion, and Dr. Resnick, this will go to you, on more of the pain dressings that have maybe the hydrogel, or again, we're talking about the cooling effects. What are your opinions on that for pain control?
With HS wounds that are denuded, that are missing skin, air contact really makes things hurt. So anything that you're going to put on there that will be occlusive, something as simple as Aquaphor or Vaseline. The hydrocolloid dressings work well, but they're difficult for a number of reasons. They cost a lot of money. They do poorly on wounds that leak a lot. But again, you've got to try it and see if it works for you. One of the other issues is that patients will often have really large areas that don't lend themselves to being covered with a single dressing. So I think that thinking about Aquaphor, which I personally prefer to Vaseline because it doesn't melt as easily and get as goopy.
Yep.
Plus a nonstick pad so that you're not ripping stuff off when you're cleaning yourself. Plus some gauze and tape or an ABD pad is a better way to go when you've got that kind of wound you want to cover. Ice packs are fine.
Yes.
On top of those bandages. So again, whatever works for you.
I'm going to have to agree with you. Stephanie Carter asks, and Dr. Kim, I think this goes back to a slide you were showing with open access to the pain algorithm that you showed the various different ones. Is that open access for all of us to view and have?
Yes. I actually shared the slides and then the study, and I can get the study.
Okay.
Because that it's free and open access as well.
Wonderful. Perfect.
There's something I'd like to add to that. Sure. There is something called Unpaywall. It's an add-on for Chrome and Firefox.
Yeah.
And if an article is available online somewhere in the world on the internet, Unpaywall will tell you that, and it'll show you a green tab with an unlocked padlock, and you click on that and it'll take you there.
Oh, that's great.
And it's free.
Yep, and it's free.
Discussed
that. Yeah.
One quick thing I want to add about topicals. We have quite a few patients using topical cannabis and cannabis creams. If you want to do that, get a cream that's made for that reason versus taking something like an oil and just putting that into the wound, because you have to just be careful of the base and how it was prepared. But people get some relief with that, and especially for joint pain. So I don't want to forget that.
Well, I'm glad you said that, because one of the questions was, I know you already discussed about not ingesting, or be careful ingesting RSO, but somebody said, what about using it on a wound?
It's not made for a wound, so it could possibly help, but we don't know whether it's helping because we believe it helps or it's actually helping. So if you go to a site or go to a dispensary, tell them what is wrong, and they will have something for you.
Okay.
Because what we don't want to do is introduce infection if somebody was not careful with their preparation, or they come back to you and say, well, that was never meant to go in a wound, or it burns, and you're like, what the heck? And, I would tell people to be very careful with RSO. It's very potent, high THC. It's not fun to take. It'll put you to sleep. And it can be really difficult and altering. So, and it's something you kind of have to commit to. So I just say, in thinking about it, really, if you talk to your bud tenders, talk to your dispenser, and tell them what kind of quality of life you want to have. And you're going to have to make some choices.
Okay. I'm going to be honest with you. It's extremely popular in the HS community.
Yeah.
So this is kind of good feedback for them to better tailor, I guess, and safety and all that.
Yeah.
And going back to the topical, you said something about the compound of gabapentin and all that. Is that typically, I know you can't answer for everybody, covered by insurance?
It depends on your compounding pharmacy.
Okay.
There's some who will try to get one drug covered. So here in Atlanta, we have a pharmacy that will push through the prior authorization for the gabapentin, and then add the ketamine and everything else just to make sure people have access. But often compounds are not always covered when you try to send them through.
Okay.
But that's one way to do it.
Yeah, that's the hard part with just about everything with HS. It's a very expensive illness.
Mm-hmm.
Dr. Kim, is tramadol addictive in your opinion?
Yeah, it can be, even though they say it's a weak opiate, but yeah, it can be. So you just can't stop it. So if you've been on tramadol kind of scheduled, you can be physically dependent. So that just means that your body's used to having it there, and if you take it away, you'll suffer withdrawal. Addiction, I say addiction is when you are taking the tramadol and it's adversely affecting your life. So you're taking the tramadol and your friend asks you, like, did you take your pain medication today? And you lie. You're taking it and you're guilty. You're taking it and you don't have pain. You're taking it because you had a bad day and somebody got on your nerves. You may not take it during the week, and on the weekend you take 10 just to cope with whatever's happening. That's addiction. Physical dependence is a side effect of the medication. Either way, you just don't stop it abruptly. Stopping it abruptly can increase risk of seizures and other side effects, and then just feeling like a weak opiate withdrawal. So I don't want. I often find patients feel a stigma like, oh my gosh, I missed my medication and now I had withdrawal. I'm a terrible person. I'm like, no, that's a side effect. You're
Right.
using it appropriately. It just means that you can't chuck it like you wouldn't stop your diabetic medication, your heart medication, because things would get out of whack.
Or steroids or anything. Okay.
Yeah.
Understood. Dr. Resnick, this one's going to be for you. So, James K has a special needs son, and we do see this a lot in the community, unable to communicate. So, how does one, in these circumstances, help their children when they're unable to say, hey, I'm in pain? I mean, how does a parent help that child?
For me as a physician, the best control of pain is control of the disease. So the obvious things are, when your child is uncomfortable, when you think he's in pain, he or she might be scratching at it or rubbing it against something, or any of the other behaviors that you're going to relate as a negative thing. So I think that the best way that you can help them is to find someone who's going to help you treat the HS and get it under control.
Okay.
And it'll be fairly obvious. You've got a massively uncomfortable kid who, when he or she finally gets some medicine that starts to make them feel better, looks better,
Okay.
smiles, interacts better.
Right.
When I see first-time patients, pain is a big thing I discuss. I try to validate the fact that they are always in pain, 24/7, 365. And they may have been dealing with it for years, so that the pain relative to how it messes with their lives has reduced because their lives have reduced and there's not that much that they're doing. And they say, well, I'm not really in pain. Patients with chronic pain issues are constantly asked, so can you rank your pain on a scale from 1 to 10? 14, 12, 77. And it's something that wears on you, and it's something that no longer seems to have as much impact. And then the absence of that pain is an amazing thing.
Yes.
So back to what you do, you find some way to mitigate the pain. You get control of the disease, you control the pain.
Yeah. And I'm glad you touched on that because, I have other illnesses aside from HS, but you're right. We do get used to it. And whenever anyone asks the pain scale of 1 to 10, we just we can't, it doesn't fit our lives. So we don't know how to tell you, I'm glad that you touched on that because I can tell you right now, a lot of people are relating to what you just said. Dr. Curseen, is there anything you wanted to add to that of what you just said?
And no, that was a perfect answer. If you need a scale, I would use the pain AD scale, which is a scale made for dementia patients who are nonverbal. And it follows along with Dr. Resnick. And it might be a way when you are calling into your doctor and you're trying to explain that my baby's in pain and you use that scale, it may be something that they remember and they may react to. Like, what are the behaviors? Well, he's hitting, he's grimacing. Those are things medical people, oh, okay, then that's true pain versus a behavior, because you now have to interface with the medical system. And remember, we're poorly trained, and we don't really know. You're having to sort of educate us, and that gets tiring.
Right.
So that scale can be helpful. But yeah, there's nothing to add. Dr. Resnick's absolutely right. I don't even ask on a scale of 1 to 10 because that's ridiculous.
Good. Thank you. Thank you both for understanding that's such a big deal. Dr. Curseen, do you know if there's any ongoing, this is a kind of a specific question. I kind of want to know if there's an answer to this.
Mhm.
And I love research. I'm a geek when it comes to that. Is there any ongoing studies of different versions of pain, kind of what you showed, but more so a specific treatment to that? So, you have your categories of pain, and then, okay, let's assign it as targeted treatment. And I know everyone's different and there's personal this and that,
Yeah.
but
Yeah, there's several randomized clinical control trials looking at different modalities of pain and trying to do targeted. Where you can find them on clinicaltrials.gov. So
mhm,
if you're feeling, every once in a while, patients who have rare diseases or illnesses, there may be a clinical trial that's going on and you don't know about it. We think about it in cancer, but they do happen in other illnesses as well.
mhm.
Um, there are lots of medical cannabis is becoming a hotter thing now.
Yeah.
Psychedelics are starting to help people manage pain and discomfort. So those are two that people in the community may hear about that your physicians may not know about. There is not a lot of money in supplement medications other than psychedelics. So that's why studies on